Welcome to Medical Review with Dr. H. Today, we are diving deep into one of the biggest topics in cardiology, heart failure. We're going to cover the whole story, from the basic why it happens all the way to the high-stakes protocols we use in the ER. Ready? Let's get into it. So here's what we've got on the docket. We'll kick things off with the broken pump model. That's key for understanding symptoms. Then we'll get into diagnosis, the two main types, cover both long-term and emergency treatment, and wrap it all up with a real-world scenario. Let's go. Okay, first things first. To really get a handle on heart failure, you've got to stop thinking of the heart as just one organ. I want you to picture it as two totally separate pumps, a right pump and a left pump, and sandwiched right between them, the lungs. This little mental model, it's the key to unlocking everything else we're going to talk about today. All right, now listen up, because this is the golden rule. If you remember one thing from this whole explainer, make it this. Blood always backs up before the broken pump. Seriously, burn that into your brain. If you can just remember that one thing, you can figure out exactly where a patient's symptoms are going to pop up just by knowing which pump is broken. All right, so let's put our golden rule into action. What happens if the right pump breaks? Well, where does the blood back up? It gets jammed up in the body's main veins, right? And that's exactly what causes those classic signs you see. The swollen neck veins, that's jugular venous distension or JVD, a swollen liver, and all that fluid pooling in the legs and feet. Okay, so what happens if the left pump breaks? Now think about it. The right pump is still chugging along, pushing blood forward, but it just hits a brick wall at the left side of the heart. So where does it back up? It floods the lungs. And that is why people get that crackling sound in their lungs, why they can't breathe when they lie flat, we call that orthopnea, and why they wake up in the middle of the night totally panicked, gasping for air. That's paroxysmal-nocturnal dyspnea, or PND. So look, when you have a patient and they tell you about this classic trio, they get short of breath with any activity, they can't breathe lying down, and they wake up at night gasping, your alarm bells for heart failure should be ringing loud and clear. Then, when you do your physical exam, there are two massive clues to look for. One is a displaced point of maximal impulse. You'll feel the heartbeat further down and to the left than it should be. The other is hearing an S3 gallop when you listen to their heart. You find those, you have to assume it's heart failure until you can prove it's not. Okay, so we're suspicious, we see the classic symptoms, but how do we actually lock in the diagnosis? Let's talk about the workup. A lot of folks immediately jump to the chest x-ray. And yeah, it can give you some good clues, don't get me wrong. You might see a big heart or some fluid in the lungs, but it's just not specific enough. You can't hang your hat on a chest x-ray to diagnose heart failure. It's just a piece of the puzzle. And it's kind of the same deal with the EKG. An EKG is absolutely fantastic for figuring out the cause of the heart failure. Maybe you'll see signs of an old heart attack, for example. But the EKG itself, it doesn't actually tell you if the pump is broken. So the first real step in our diagnosis is a simple blood test for something called BNP. Your heart releases this hormone whenever it's being stretched out by too much fluid. Now, it's not a perfect test. Other things can make it go up, but it is super sensitive. And what that means is if the BNP comes back normal, you can be almost certain it is not heart failure. It's an amazing test for ruling it out right at the start. But the real money shot, the test that gives us the definitive final answer, that's the 2D echocardiogram. It's basically an ultrasound of the heart. And honestly, it is the single most important imaging test we have for this. It tells us not just if there's failure, but exactly what kind of problem we're looking at. And this is where we see the two main types of failure. On one side, you have systolic dysfunction. Just think big and floppy. The heart muscle is weak and stretched out. It just can't squeeze properly to pump blood out. This gives you a low ejection fraction, or EF, which is just the percentage of blood the heart pumps with each beat. Anything under 50% is a problem here. Then, on the other side, you have diastolic dysfunction, which we now call heart failure with preserved ejection fraction, or HFpEF. For this one, think thick and beefy. The heart muscle is so thick and stiff that it can't relax to let blood in. The squeeze is actually fine, which is why the ejection fraction is normal, or sometimes even high. Okay, we've got the diagnosis. We know what type it is, so what do we do about it long term? Well, that's where the New York Heart Association, the NYHA, classification system becomes our roadmap. It basically guides every single treatment decision we make from here on out. This table really lays out the whole game plan, and you can see how we layer on treatments as things get worse. So every single patient, no matter what, starts on two core medications, a beta blocker and an ACE inhibitor. That's class 1. Then, once they start getting symptoms with exertion, like walking up a flight of stairs, that's class 2. That's when we add a diuretic to help get rid of that extra fluid. If things progress and now even simple daily activities are a struggle, that's class 3, and we bring in heavier hitters like spironolactone. And finally, for our class 4 patients, the ones who are short of breath even just sitting on the couch, we have to pull out the big guns, powerful IV drugs, mechanical heart pumps, and sometimes a heart transplant is the only option left. Okay, stop for a second. I need you to remember this number, 35%. Just burn it into your brain. If a patient's ejection fraction falls below 35% and they're not yet in that end-stage class 4, they need an AICD. That's a defibrillator implanted in their chest. Why? Because the risk of them suddenly dying from a dangerous heart rhythm is incredibly high, and this little device is literally a lifesaver. It's a non-negotiable. And look, the meds are just one piece of the puzzle. The lifestyle stuff, it's completely non-negotiable. We're talking a very strict limit on salt, less than 2 grams a day, and fluids, less than 2 liters a day. You have to control the volume going in. And of course, smoking has to stop, period. And we can't forget the underlying cause. If their heart failure is because of blocked arteries, what we call ischemic heart failure, then they also have to be on an aspirin and a statin. You have to treat the root problem. So that's the chronic day-to-day management. But what about when it all goes wrong? What happens when that patient comes into the ER, they're in a full-blown crisis, they're drowning in their own fluid, and they can't breathe? For that nightmare scenario, we have a very specific step-by-step protocol. Just picture it. The alarms are going off, a patient is rushed in, they can barely speak, their O2 sats are dropping, they are in major distress. In that moment of chaos, before you reach for a single heart failure drug, what is the one thing you have to rule out first? It's a heart attack. You absolutely have to rule out an MI. Why? Because an acute MI can look identical to a heart failure flare-up, but the treatment path is completely different and every second counts. So first things first, get that EKG, get those troponins, and make sure this isn't a heart attack. Okay, so you've ruled out the MI. You're confident this is a straightforward CHF exacerbation. Now you unleash the classic mnemonic, LMNOP. L is for Lasix, the big gun diuretic to pull all that fluid off. M is for morphine, and N is for nitrates. They're both great because they open up the veins, which keeps more blood in the legs and takes the pressure off the lungs. Then you've got O for oxygen, obviously, and P for position. Sit the patient up. It makes a huge difference for their breathing. It's just a simple, systematic way to get the patient stabilized fast. All right, enough with the theory. Let's put this into practice and see if it's all making sense. I'm going to throw a quick clinical case at you and see how you do. Okay, here's the setup. We have a patient with a known history of ischemic heart failure. They come in saying they're getting winded just from walking around the grocery store. What does that sound like? Yep, that puts them squarely in NYHA class 3. And we check their chart, they're already on the 2 starter meds, lisinopril and carvedilol. So, you've got the info. You know the cause is ischemic, and you know they're class 3. The question is, what's the next move? What do you add to their medication list right now? All right, did you get it? If you followed the roadmap, you know there are 3 moves to make. First, because it's ischemic, they absolutely need an aspirin and a statin. That's a must. Second, they're symptomatic, so they're past class 1. That means they need a loop diuretic to handle the fluid. And third, because they've hit class 3, it's time to add the next layer, which is either spironolactone or that isosorbide dinitrate hydrazine combo. It's just like building blocks, one on top of the other. And really, that brings us to the big picture. What's the most important thing to take away from all of this? I think it's that managing heart failure today isn't just about reacting to emergencies. It's a system. It's a proactive, step-by-step process. If you can just remember that simple blood backs up before the broken pump model, you can understand the symptoms, order the right tests, and then layer on the right treatments at the right time. And it's that system, that's what has turned heart failure from what used to be a death sentence into a chronic disease that we can actually manage and help our patients live much longer and much better lives.